Welcome everyone to the ECG crash course. Today we'll be going through pericardial problems. So just a quick bit of anatomy. The heart's held within a sac called the pericardium, and the pericardium is split into two main types. We have the fibrous pericardium, which is just seen here, and it's been cut open in this cadaveric dissection to expose the heart, and it covers both the heart and the great vessels. So here we have the aorta, and there we have tucked away is the pulmonary artery. The other part of the pericardium is called the serous pericardium, and the serous pericardium is split into two further subtypes, and that's known as the parietal pericardium, which is very tightly adhered onto the fibrous pericardium, and then we have the epicardium, also known as the visceral pericardium, which is adhered onto the heart itself, so it would be tightly adhered onto the myocardium and also the coronary arteries, our epicardial vessels. Between the parietal pericardium and the serous pericardium lies a pericardial cavity with pericardial fluid. So you can see this heart juice just there. And that acts as a lubricant to reduce the friction when the heart contracts. And this is just a nice diagram from Teach Me Anatomy to represent those layers. So what can go wrong with the pericardium? Well, there's two main diseases that you really need to know with the pericardium. It can either become inflamed, and we call that pericarditis, of which there are many causes such as viruses, bacterial infections, TB, cancers, etc. And there's certain pericarditises that you might be required to know, such as constrictive pericarditis, which is outside the scope of this lecture. And the other thing that can go wrong with the pericardium is it can just fill up with loads of fluid, and we call that a pericardial effusion, and in an emergency setting we might call that a cardiac tamponade. So how can I identify pericarditis on an ECG? Well, you just look at any of the leads. So in this case I've chosen V5 in this example because it shows the findings quite nicely. And you quickly identify that it's sinus rhythm. In this case we can see a P wave, QRS and a T wave. And then we'll draw the isoelectric baseline in, which is that invisible line, that goes through the ECG. So, get the pen out, and I'll try to make it as nice as possible. But drawing on these things is quite tricky. Okay. So it's not the best isoelectric line, that could be a bit more higher, but essentially this should be able to illustrate the points, and we'll have further examples later on which show them a lot more clearly. So firstly, the first finding you'll see is PR depression. So you have PR interval depression. So remember the PR interval is measured from the start of the P wave to the start of the QRS, and the PR interval is slightly dipping below the isoelectric baseline. So a PR depression is the first finding you'll find, and you can see it again there, and you can definitely see it there. Second finding you'll see is ST elevation. And ST elevation usually in pericarditis looks concave in nature. So that's usually what you see. So it looks a bit like a saddleback, ST elevation. It can be confused with an ACS sometimes because that shows ST elevation as well. Check out my STEMI and NSTEMI video for more information. But in a pericarditis, usually the chest pain that presents is slightly different to an ACS. You usually get more of pleuritic chest pain that's worse on lying forward. That's better on lying forward, and worse when lying flat. And you might have like feverish symptoms as well. So better on lying forward, worse on lying down. So the other lead you want to look at is lead AVR, and lead AVR is just used to look for reciprocal changes, which are just basically opposite changes basically. So again, we'll draw the isoelectric baseline in. Great, again, not a very good example of an isoelectric baseline because I'm very rubbish at drawing with a mouse, but you'll see instead of PR depression, you'll see a PR elevation here, and you'll see an ST depression. So AVR is just basically used to show the reciprocal changes that the other leads would be showing. And that's because AVR is found in the extreme axis. So here we have an example. A 56-year-old male presents with pleuritic chest pain. He mentions that he had a heart attack around about 7 weeks ago. He's worried that he might be having another heart attack. On auscultation, you hear precordial rub. You request an ECG. This is his ECG, that should pop up. So analyse the ECG. So feel free to pause the video, work it out yourself. Otherwise, I'll go through it now. So firstly, we can see a P wave, a QRS followed by a T wave. So we know this is sinus rhythm. We can now assess for other changes. So we can see that the QRS isn't particularly broad. It's within 120 milliseconds. So we know there's no underlying bundle branch block. And then if we look at our ST segments, we can see that in a lot of our leads, they're fairly elevated. They're quite elevated there. If we were to draw in the isoelectric baseline, we can see that they're fairly elevated in quite a lot of our leads. And we can see abnormal T-wave abnormalities, and we can see T-wave abnormalities in our precordial leads. If we now look at our PR interval, we can see there's no sort of underlying first degree AV block because it's not greater than one big box. However, we can see, if I was to zoom in on that example, we can see that the PR interval is depressed. And if we were to confirm that on our AVR, we can see that the PR interval is elevated and our ST segment is depressed. So this is likely in keeping with a pericarditis. And if we look at our symptoms, the patient has pleuritic chest pain instead of that retrosternal crushing chest pain. He did have a heart attack 7 weeks ago, so he has had some background of ACS. So the fact that he's presented with what seems like a pericarditis following a STEMI 7 weeks ago, this is likely something called Dressler's syndrome, which is a specific form of pericarditis that specifically occurs when you've had a ACS. So, and also he has a precordial rub, which is a physical examination finding that you might hear in patients with pericarditis. So well done if you got that correct. If you didn't, I hope this example illustrates how to recognize pericarditis in an ECG. Please also be aware that as pericarditis, as the patient begins to recover from pericarditis, you do get dynamic ECG changes. So over the weeks of recovering from it, the ECG, the STs will begin to normalize, the T waves start to become flattened, and then they become inverted, and then a couple of weeks after that, then the ECG will go back to normal. So depending on the point where you pick up the pericarditis or the point where the patient presents, the ECG findings might look a bit different. So what will I see in a pericardial effusion? So so we'll go through this example, and I'll get my pen out again. So firstly, we'll quickly confirm if it's sinus rhythm, and we can see it is sinus rhythm. There's a P wave followed by a QRS followed by a T wave, and a P wave followed by a QRS followed by a T wave, or a very flat T wave there. And we can see here that that the QRS isn't particularly broad, so we know there's no underlying bundle branch block. So now we'll look at everything else. So looking at the ST segments, we don't particularly see any abnormal STs in our leads. There might be some slight high takeoff there, but nothing that looks abnormal. Now let's look at our QRSs. So we've already confirmed there's no underlying bundle branch block. However, if you've noticed, this QRS is tiny, and then this QRS becomes big, and this QRS becomes tiny, this QRS becomes big. So there's sort of like a fluctuation in our QRS sizes, and that particular finding on an ECG is called electrical alternans, because the QRS is alternating in amplitude. And we can also see in this example that the patient's heart rate is particularly fast, so this is a sinus tachy with electrical alternans, and that's a finding that's most likely to occur in a pericardial effusion. So that's the example there. And why does that electrical alternans occur, I hear you say? So this is an echocardiogram of someone with a pericardial effusion. And this is the heart, so this is the left atrium, right ventricle, left ventricle. And you can see that the heart's sort of swinging. And all of this black stuff is all fluid, and that's pericardial fluid. So this would be the fibrous pericardium here, fibrous pericardium there. This would be the sort of epicardium there, that sort of white line around the heart, and that would be the heart contained within it. And all this black stuff here is fluid, and the heart's sort of just swinging in that fluid, and it's rocking back and forth, and that swinging motion is what creates our electrical alternans. So that's just a nice representation on echo of why you see an electrical alternans. So now it's practice time. So with each of these ECGs, feel free to pause the video, work it out yourself, and then I'll show up the answer, and then we'll go through it if there's any confusion. A 58-year-old female who had recently undergone an elective CTO procedure 25 minutes ago complains that she feels really unwell. You ask the nurse to do a blood pressure and a quick 12-lead ECG. Her blood pressure comes back at as 81/58 millimeters mercury, and her ECG is shown below. Feel free to pause the video and work out the interpretation, and the answer is going to come up in 3, 2, 1, 0. So this ECG shows a sinus tachycardia at a rate of 125 beats per minute with an electrical alternans, and this is likely a cardiac tamponade. So for anyone who doesn't know what a CTO is, that's a chronic total occlusion. It's a specific sort of procedure that patients undergo in the cath lab when they have a chronically occluded coronary artery. It's a very long specialist procedure where a lot of invasive equipment, a lot of interventional equipment is popped down the patient's coronary arteries. So for whoever didn't know what a CTO is, that's basically what one is. And I assume she's probably on the cardiac day case unit. So that's basically just the context of the case. So well done if you got that right. If you didn't, let's work it out together. So firstly, just confirm it's sinus rhythm. So P wave, QRS, a very flat T wave, P wave, QRS, T wave. So this is sinus rhythm. And if you're to work out the R-to-R interval, a nice R-to-R interval to probably use is this one. And then here, and that looks around about 5, 10, around about 13 boxes. So if you work out the heart rate from that, you should get roughly 125 beats per minute. So where's the electrical alternans? Well, if you look at lead 2, because it's a really nice rhythm strip for this, you can see a big QRS, small QRS, big QRS, small QRS, big QRS, small QRS, big QRS, small QRS. So there's definite electrical alternans there. And and obviously we also have in the vignette, we can see that there is a low blood. She's hemodynamically unstable, which again sort of alludes to the suspicion that there might be a cardiac tamponade. If you do a physical examination of her, you might notice that she might have a raised JVP, and if you were to auscultate her heart, her pericardium, you might notice that there's muffled heart sounds, which all links to Beck's triad. So just continuing the case, because it's an interesting one, you decide to do a POCUS, a point of care ultrasound, and this is the ultrasound you get. So we'll interpret this quickly. It does not take a genius to see that there is pericardial fluid around that's surrounding the heart, and the heart does not look like it's contracting correctly. But to quickly orientate yourself, this is the left atrium, right ventricle, left ventricle. And in cardiac tamponade, or in patients who are hemodynamically compromised with a pericardial effusion, so that's all that black stuff there, you can see here that the right atrium is being squished by that fluid, and also that the right ventricle is beginning to become compressed by that fluid. So the issue with a cardiac tamponade is that the heart's ability to relax in diastole is very impaired because it's not able to relax because of all that fluid around it, essentially, that basically compresses it. So that's what begins to cause that drop in cardiac output. And also, because the right atrium and the right ventricle are being compressed, venous return isn't going to be very great from the IVC and the SVC, and that's why, especially with the SVC, which is connected to our jugular vein, that's why you see that JVP, that elevated JVP, because of that poor right-sided return, because the right ventricle and the right atrium are being compressed. Blood can't get in there anymore. So that's just a nice way of visualizing that on ultrasound. And obviously the muffled heart sounds occur because you've got all this fluid going around it. And the heart looks hyperdynamic because it's trying to use it's trying to increase its heart rate to sort of compensate for a reduction in cardiac output. If you think of that equation of stroke volume equals cardiac output times by the heart rate, if our cardiac output's going down, our heart rate has to go up to sort of maintain or attempt to maintain that cardiac output. So what in this case, why did a cardiac tamponade occur? So remember, this patient had a really complex coronary intervention, and that puts them at somewhat of a risk of having a tamponade because the interventionist might have accidentally poked a wire somewhere where they shouldn't have. And in this case, if we orientate ourselves, this is the left main stem, the circumflex, which we can see really nasty disease there. But in this case, the focus is on the LAD, which is this one that goes all the way down to the apex of the heart. And if we look just there, well, it's pointed out for you, but I'll just zoom onto it for obvious reasons. We can see that there's this little puff there, and that puff, or that sort of cloud of contrast, is essentially it's basically contrast that's leaked out of the coronary artery, and that's because they've likely, when they've wired the vessel, and this is the wire here, this black line here, that's an interventional wire. It's likely poked a hole into the coronary artery, and that's caused contrast to leak out. And in this case, the interventionist didn't see this very subtle perforation, and that's what's so when they've sent the patient back to the coronary day case unit, that perforation has continued to leak out blood, and that's what's caused our cardiac tamponade. And remember, a cardiac tamponade doesn't need a lot of fluid or a lot of fluid to to cause hemodynamic compromise, because it's the rate of fluid that's important with a cardiac tamponade. You can have massive pericardial effusions where the heart's basically just chilling. It's had enough time to adapt to that external pressure and contract normally. However, if a little fluid builds up really quickly, the heart's like, whoa, what's going on? And so it doesn't have enough time to compensate, and so the heart struggles to deal with that. So that's just something to be aware of. In real life, interventionalists are this make-believe interventionalist was clearly not very good. In real life, interventionalists would not miss that, and that would be promptly covered with a coveted stent or coiled. So a 61-year-old male presents with fever symptoms and some chest pain. He mentions he recently came back from a holiday in the Philippines. You decide to do an ECG. That's his ECG. Feel free to pause the video, work it out yourself. Otherwise, the answer will pop up in 3, 2, 1, 0. So this is atrial fibrillation with widespread ST elevation, likely in keeping with a pericarditis. So, well done if you got that correct. If not, we'll quickly work it out. So, quickly looking for a P wave, we don't really see any distinct P waves. We can see some fib waves in lead 3. We can see really clear fib waves in lead V1. So this is atrial fibrillation, and we can also see that it's a irregular rhythm, we can see that the R-to-R interval between each beat varies quite a bit, and so we're affirmative that this is atrial fibrillation with what appears to be a variable ventricular response. It goes a bit slow here and then it speeds up a lot there. We can see that QRS isn't particularly broad, so it's less than 120 milliseconds, so we can say that there's no underlying bundle branch block. Now looking at everything else. So the ST segments already look elevated in lead 1, lead 2, in AVF, slightly in leads 3, although there's some significant baseline wonder. I wouldn't call this a very high quality ECG. And then we can see some slight high takeoff in V2, V3, V4, V5, and V6, which again, so we'd call this widespread ST elevation. We can't assess for any PR depression because atrial fibrillation doesn't have a PR interval. However, if we look at our reciprocal changes in AVR, we can see that it's depressed. So we've confirmed it in AVR. So this is most likely in keeping with the symptoms, a pericarditis. So what could have likely caused this pericarditis? Well, he's travelled to the Philippines, he has a fever, he's got some chest pain. It's likely that he's picked up an infection from the Philippines. This could be TB, because there is a high level of TB prevalence in the Philippines. So this could be a TB as well that's caused a pericarditis. So well done if you got that right. If not, you'll get better with practice and experience. So thank you for listening to the video. I hope you found it useful. Feel free to check out my other videos, and I'll catch you in the next one.